Hi there guys, welcome to part 2 of our 2021-2022 application cycle overview. My name is Mohammed. I'm one of the co-founders alongside Uzi and Jamie, who unfortunately can't be here. If you've not watched part 1, I don't know what you're doing. I don't know why you've jumped into part 2, but hey ho, go back and watch that one because that provides a generic overview of the application system. This one is going to be focused specifically on the multi-specialty recruitment assessment and how it was used during the 2021-22 application cycle. So like I said, this is going to be all about the MSRA, not the MRSA, which people say for some bizarre reason is the MSRA. So what is the MSRA? Now, if you already know, just skip ahead. But this is a computer-based exam that was originally set up for GP recruitment. 2016 onwards, at the point of recording, it's still used by the RCR as part of the application process. Number one, to decide if you're shortlisted, basically invited for an interview, if you meet the cutoff score in your MSRA performance. And then finally, as of the 2021-2022 cycle, it was worth up to a third, 33% of your final rank. So a big deal, if I'm honest. You sit at the Pearson VUE test centres. For those of you in the UK, you may remember going there to sit your theory test exam for driving, and all the high hopes you had of medicine and foundation training and what you thought you'd achieve in a medical career. But hey ho, let's not go down that rabbit hole. And at the time of recording this, for the 2021-2022 cycle in particular, candidates who were shielding because of COVID specific reasons, and please note these were specifically quite strict COVID reasons. For example, you had a vulnerable person that you were a carer for that you had to take and you didn't want to expose them to COVID. You could then sit the exam remotely on something known as OnView, but there were strict criteria, not like, oh, you switch on your laptop and have a go and basically cheat. You had to keep your webcam on at all times. They would monitor your eye movement, for example. You had to have your mic on. You'd be monitored throughout the entirety of your exam. So you could do it, but you had to meet the eligibility criteria and you had to tell them early on. So if you think you may still require this, then please look at the eligibility criteria on the Pearson VUE website and get in touch with them to let them know early on. Maybe you need to fill in some documentation, provide some evidence. You don't want to be collecting all this a week before your exam date. Now, in terms of the structure for the 2021-2022 cycle, there were two components: professional dilemma, the clinical problem solving. You can see the breakdown of the questions, how many there were, how many were pilot questions. For example, professional dilemmas, basically the SJT equivalent, which everyone remembers doing and regretting because it was so ridiculous, but hey ho. Like for example, on your screen you can see that 42 were counted, 8 were there for a pilot. You don't know which are a pilot because obviously any sane person would just skip them, because why are you going to do questions that don't matter? But you don't know and you have to do them because they're used as pilot. There's no negative marking. It's not that cutthroat. And like I said, you don't know the pilot question, so have a go, do your best, then afterwards get a strong drink basically. Now, this talk is quite short, this application part, this MSRA, because we're not experts. The only thing we are experts of is having done the MSRA, not how to smash the MSRA. We're just glad that we've done it, and hopefully touch wood never have to do it again unless they now make it mandatory for consultant interviews. In that case, I don't know what I'm going to do. But there are always two categories of applicants since we've been doing RadCast and helping candidates with their applications since 2018. There's one cohort that go, oh my god, this means a lot, I need to take it seriously, and then pull up their trousers and crack on with the revision. Anecdotally, and we're now starting to see evidence that we're collecting, they kind of do very well on the MSRA, like comfortable scores that are above average. The other cohort, unfortunately, kind of think, no, well, I'm a practicing doctor now. Some of you may be senior med regs, surgical regs, other registrars in other subspecs. And very well, I'm practicing, I'm a junior doctor, so I should be okay. You're not going to be okay, all right? This exam is not a case of what do you do clinically day to day. This is what is best practice, which often may not be reflective of what you do, especially the ethics side of things, which, as we all know, varies depending upon practices within the actual trusts. And there are certain elements of your medical training that you may not have covered since your medical school finals, which may now, if you're a foundation year 2 doctor, may have been 2 years ago. Okay? For example, Developmental milestones. If you're a geriatrics reg, I don't think you're looking at developmental milestones every day. Definitely you're not. If you're an ophthalmology reg, when's the last time you looked at gynecological emergencies? This exam is a lot about breadth of knowledge, not depth of knowledge. And there's a large amount of content that you need to go and brush up on. Heme oncologies, heme emergencies, different types of anemia. Like, it's different to what you do clinically day to day in. And revision will take time because, listen, you're not a medical student who can just basically ignore your work for 9 months of the year and then the final 3 months cram. All right? It isn't like that. You now have on-calls. You now have something, a life to live. So trying to find the time to revise for quite a broad exam does require some input. And if you fail to prepare, you will prepare to fail. Now, that's like my saying of the decade, if I'm honest. And any marks that you lose in the portfolio in the interview, for example, the dreaded additional degrees, where you're like, man, I wish I did that integrated degree in philosophy, ethics and law, but I thought, what's the point? I just want to graduate. These marks can be easily made up in the MSRA because remember, your raw mark is scaled and that multiplying factor can change depending upon the performance of the cohort who are applying to radiology with you. So those marks you may not have for doing degrees or publications, you can easily make up because it becomes your buffer, especially in the interview where for most of you may have not had an interview since med school applications, so you're going to be rusty. You can have this cushion through the MSRA, and like I said, there's no negative marking, so there's nothing to lose. Just give it your best shot. In terms of resources, there are several which I'm going to go through this talk. The first is this good medical practice. This, you could call it your Bible, all right? If you haven't read this, you need to. You're probably told to read this in medical school, but who does? Like, I personally didn't. But when we were preparing for the MSRA, you should read this because there's a lot of principles that kind of dictate how you do from an ethical perspective. And the GMC is basically your reference point. Like, if the GMC say do this, or if the GMC say jump, you need to ask how high. All right. So if they recommend a certain course of action and then that question comes up, especially in the ethics side of things, then guess what? You're going to pick the same answer as the GMC. But obviously we know ethics can be quite dull, especially in the textbooks where you want to fall asleep because it becomes quite complicated, a lot of complex terminologies that we're not familiar with and principles. These GMC medical practice in action puts it into context with clinical scenarios, and really, like, I'm really glad the GMC have made this because it kind of makes ethics approachable and it's interactive. So you can see, okay, if I pick this answer, why do the GMC not agree with my actions? Okay, if I do it this way, why do the GMC agree with my actions? And they reference guidelines or principles that you should be aware of, which you can read in your spare time. Now, when it comes to books, please don't go like over the top. I know we medics love to collect textbooks, especially now that we have like online Kindle books, but please don't. All right, there are 3 books that we would really recommend. Number 1 is the up-to-date Oxford Handbook for both general medicine and clinical specialties, your cheese and onion, your salt and vinegar. I don't know if they're still called that, I may be too old. And in the middle, you can see the situational judgment test. Now, please take the SJT, the ethics books, with a huge pinch of salt. Often, these books are outdated. And number 2, they don't have access to the assessors' viewpoints because assessors who write these exam questions sign a declaration saying that they cannot be part of a group that writes these books because obviously you've got a conflict of interest. So if you don't know what the assessors are thinking when it comes to how they differentiate the marks, then really these textbooks for SJT in particular become a question of my opinion versus your opinion. And this is where arguments happen. Obviously these are trivial, useless arguments, but when it comes to revising, it becomes a headache when you're like, actually I disagree, but the answer goes against my thought process. Why? And then when you look at the answers, they're like, actually this makes no sense. So really be careful about what ethics books you get, especially when you're trying to get rigid rules. That's why we like this Oxford Assess and Progress, because they often reference to a lot of guidelines, which, if I'm honest with you, is how you should be framing your ethics. Not, oh, I said do this, so you should do it. When the assessor may be like, actually, that's a load of nonsense. That's actually unethical. Mohammed, so why are you doing it like that? Because I don't have access to the assessor's brains. So don't overly rely on these ethical books for the SJT, the professional dilemmas part of your MSRA. In terms of question banks, there's a whole range of them. You've got eMedica, MCQ Bank, Past Medicine. Now, in terms of our approach, what we find works best is that the clinical side of things, the Past Medicine is often a very good resource. Why? It's very guideline driven. Like, it'll give you a question on hypertension guidelines, you'll get it wrong or you'll smash it, and then in the answer stem it'll say, bam, here are the nice guidelines, and you're like, okay, done, that's my revision done. I'll look at this algorithm on the nice guidelines website and boom. That's how your clinical medicine approach should be. It shouldn't be subjective. MCQ Bank, one of the reasons we really like it is, once again, it's very guideline driven, but there's access to a lot of questions, especially the ethics side of things. And obviously you have eMedica, which is another resource if you're interested in. But please don't bombard yourself with all three at once. You need to be systematic. Finish one, move on to another, because you need to have breadth of knowledge, not depth of knowledge. And if you get all three at once, guess what? You're probably not even going to do one. Okay? So just make sure that you start with one, finish it, learn from it, and then move on to the others. If you want a good discount code for MCQ Bank, we've managed to secure one. It's RadCast6M. Please know that the R and the C are capital letters, and this will get you access, well, a discounted access to the MCQ Bank MSRA prep resources. So that's the second module of this application series. If you want to get in touch, it's hello@radcast.co.uk. There are socials. We do check them. Slide into our DMs if you want to. And then we'll see you on into the third module. Take care, guys.